So inside out technique, as we all know, all repairable tears involving posterior horn and body of the meniscus. Rather, the indication has been extended towards anteriorly with the invent of this zone navigator and zone specific cannulas. The inside out technique is considered as good gold standard because of its ability to treat nearly all types of tears and the excellent fixation it provides because of low profile needles and because of less harm to the meniscus, because of the less damage to the meniscus. And it is also cost effective gadget. But it requires experienced assistant to retrieve the needles, potential risk to neurovascular structures, need for accessory incisions like posteromedial and posterolateral safety incision, and there is flexion contracture of the knee. So what are the solutions? You should do a good saphenous nerve isolation, suture to be tied in relative extension and directly on the capsule, pike resting for a good view, by putting sutures on both surfaces to give a good stability, and for lateral side, reduction stitch is very much helpful. So all inside techniques for all tears, peripheral and central in posterior and middle third, for all tear types. It is extended to the anterior part also because of invent of flexible, this all inside devices. It provides good visualization, very good, it has a shorter operative time and faster post-op recovery, avoids the need for posterior incision and lowers the risk of neurovascular injury. Currently, all inside repairs are two types, meniscus-based and capsular-based repairs. Capsular-based devices allow for biomechanically stronger repairs, but incorporation of the surrounding soft tissue poses a similar risk to inside-out repairs. But meniscus-based repairs can mitigate this risk by restoring the tissue continuity without fixing the meniscus to the surrounding soft tissue, restoring the knee contact area, avoiding hyperstability. But it has its own disadvantages. Use of older and more rigid all-inside implants causes cartilage injury, device migration, and device failure. However, the modern all-inside devices also can result in local soft tissue irritation and swelling with nerve irritation, and most of these implants are expensive. So what the literature says, some of the literature, they have concluded that there is increased rate of clinical failure and implant related complications for all inside repairs compared to inside out, but several others report equal functional outcomes, healing rates and complication of both these techniques. Like this AJSM review article, which tells that there is no differences were seen in failure rates, functional outcome scores, or complication rates between these two techniques. Similarly, this was a meta-analysis which suggests functional outcomes are overall comparable between the techniques. So one biomechanical study was conducted on the radial tear repair using cross-stitch all-inside techniques, vis-a-vis inside-out technique, vis-a-vis all-inside capsular-based repair. And they concluded that inside-out and meniscal-based techniques were superior with regard to load to failure and displacement after cyclic loading. And this was a propensity-matched analysis on the basis of age, sex, tear laterality, rim width, and concomitant ACLR in 20 patients who underwent all-inside capsular-based repair of BHT to 20 patients who underwent inside-out repair with a mean follow-up of 4 years, 4.4 years. And they found no significant differences in IKDC scores, Tegner scores, range of motion, or rate of complication. And in this study of AJSM, they told the differences in observed healing rates after meniscal repair more dependent on the tear pattern and associated ACLR rather than inside out versus all inside surgical approach. So both the techniques has its own advantages and disadvantages. If done in properly indicated cases with good expertise hand like Mukesh and Sheetal, will give a very good outcome and predictable outcome. Thank you.